Assalamu alaikum everyone. Happy Friday, Juma Mubarak. Today I want to discuss a very important topic that is dengue hemorrhagic fever. As you know, it's quite prevalent in our country. All the hospitals, almost all the hospitals recruiting MOs these days, want that the candidate should be having a sound knowledge of this dengue. As a practicing doctor in Pakistan, whether a medical officer, simple MBBS medical officer who doesn't have any other qualification, MCPS, FCPS, or any other sort of qualification, what to talk of other qualification who doesn't even have any sort of PG training, must be knowing about this dengue. All the PGs, irrespective of their specialty, should be knowing about this dengue. And what to talk of a medical officer or a PG, even a house officer, should be having a sound knowledge regarding the management of dengue. So, all of us did study regarding this dengue in our med school, but as doctors, we should brush our knowledge. So let's get started. So I've got this 21st edition of Davidson from my med school days, and I shall be revising dengue from it. So this won't be the entire video regarding dengue. It's just the beginning, and we shall continue discussing dengue in our upcoming lectures. So, dengue flavivirus is a common cause of fever and acute illness in the tropics. It is endemic in the Southeast Asia and India and is also seen in Africa, the Caribbean, and America. So, a very nice diagram is given in the 21st edition of Davidson. As we can see, that dengue is prevalent in Pakistan, in India, parts of Africa, and Caribbean, and some parts of America, other parts of America, and uh, I'm not sure, but I have read this. I've gone through it a few days back, and what I got to understand was that dengue fever is similar to this yellow fever. We shall be discussing dengue in our further videos, and in some upcoming video we shall be comparing yellow fever and dengue fever. Obviously, as a practicing doctor in Pakistan, if we don't even know about yellow fever, it doesn't make any marked difference. Though we should be knowing yellow fever if we want to be a competent doctor, but if someone is lazy or uh, due to any other reason, at least while practicing in Pakistan, dengue is a must. So let's continue. So this is a nice diagram regarding its endemic. So if we see the endemic in Pakistan, we can see that it is prevalent in entire Pakistan except for Kashmir and Sindh. But a few days back, I was watching news, and I got to know that it's even prevalent in Karachi. So I guess now it's a major problem in entire Pakistan, and obviously in Punjab, it's a very, very, very major issue. So the primary vector is the mosquitoes Aedes aegypti, which breeds in standing water, collection of water in containers, water-based air coolers. Entire dams are a common environment for the vector in large cities. Aedes albopictus is a vector in some Southeast Asian countries. There are four serotypes of dengue virus, all producing a similar clinical syndrome. Hemotypic immunity after injection with one of the serotype is lifelong. So this is a very catching sentence. Hemotypic immunity after infection with one of the serotype is lifelong, but heterotypic immunity against the other serotypes lasts only a few months after um, injection. Now, the clinical features is the most important topic in this dengue, because obviously, for diagnosing a case of dengue, we should be knowing this entire literature quite well. So the incubation period is 7 to 6 days. And before going into further theory, we should see the box. So, what are the early symptoms? There is 2 days of malaise and headache. So, if a patient comes to your ward and he complains of 2 days of malaise and headache, now obviously we are not quite sure, but in these days, uh, our first suspicion while living in Pakistan should go towards dengue. So, what does happen with the patient? He or she has got fever, backache, arthralgias, headache, and generalized pain, pain on eye movement, lacrimation, anorexia, vomiting, relative bradycardia, and this he or she may collapse, depression, lymphadenopathy, and bloody red eyes. These are quite typical features, and it is more severe at extremes of age, like in childhood and in elderly population, like 60 plus people. Fever is continuous or saddleback, which breaks on fourth or fifth days and then reoccurs after a week or so. And it has got a characteristic rash. Now, in its diagnosis, this rash is very, very important. Anyone giving history of malaise or headache, fever, backache might have some other condition also. And mostly in fever, one has tachycardia. But in dengue, one is likely to have a relative bradycardia. Now, the other day I met a person and he was like, one of his relatives is otherwise fit, but he is having bradycardia. And I was like, he was like, his pulse rate is around 45. And I was like, immediately take him to the emergency of some hospital. That person was non-doctor, and so was the patient. And he was like, what is the treatment? I was like, the treatment is atropine in emergency. But obviously, I was suspicious that otherwise he doesn't have any other known disease or something like that. So I was rather shaky that maybe he is having dengue. So in these days, anyone having relative bradycardia is most likely to be a victim of dengue. So, what's the rash like of dengue? There is initial flushing, faint macular rash in the first 1 to 2 days. So, anyone with fever, malaise, and relative bradycardia having initial macular rash, okay, maculopapular scarlet morbilliform rash from days 3 to 4 on trunk. So, in this, there is a rash on trunk which spreads centrifugally and it spares palms and feet. So, this is a very important catch point over here. The rash is initially flushing faint maculopapular rash in the first 2 days, but from third to fifth day, it becomes maculopapular scarlet morbilliform rash. Convalescence is slow. Now, the complications are really important. Hepatitis is already quite prevalent in our country, and now due to this endemic of dengue, one of the complications of dengue is also hepatitis. So we are already fighting with hepatitis, and this dengue is further contributing to hepatitis in our country. So in complications, there can be minor bleedings from mucosal sites, hepatitis, cerebral hemorrhage, or edema rhabdomyolysis. So we continue with the theory. Asymptomatic infections are common. Like I told you, I met a person who was telling that his relative is asymptomatic otherwise, but he does have this bradycardia. But the disease may be more severe in infants and elderly, as already told. A morbilliform rash with characteristically blanches under pressure may occur often as fever is settling. So it's quite interesting that patient gets a fever, but as the fever gets starts to settle, as we have already studied that it has got a saddleback pattern in which it breaks on fourth or fifth day. There is a rash which blanches, morbilliform rash which blanches under pressure. Now, it can take a more severe course known as dengue hemorrhagic fever or dengue shock syndrome. Um, in mild forms, there is thrombocytopenia and hemoconcentration. So, on labs, we can see there is thrombocytopenia, along with there can be a fourfold rise in IgG, and also the LFTs can be deranged. We will discuss it further when we read it. Um, Okay, where were we? In most severe forms, after 3 to 4 days of fever, hypotension and circulatory failure develops with pleural effusion, ascites, hypoalbuminemia, and features of acute respiratory distress syndrome. So, even this dengue hemorrhagic fever can lead to ARDS, minor petechiae, ecchymosis, epistaxis, or obviously common, but if major, it is quite dangerous because it can lead to gastrointestinal or cerebrovascular hemorrhage. And the pathogenesis is unclear, but pre-existing active or passive immunity to dengue virus serotype different to the one causing the current infection is a predisposing factor. So what is the pathogenesis? Obviously we don't know it clearly, but what is in our knowledge that active or passive immunity to a dengue serotype different to the one causing the current infection. So as we already read about this homotypic immunity and heterotypic immunity, obviously from that we can correlate it. These heterotypic antibodies cause enhanced virus entry and replication in monocytes in vitro. Cytokine release is thought to be the cause of capillary leakage, causing effusion. Obviously, effusion is most likely to occur in dengue hemorrhagic fever, and disseminated intravascular coagulation. So, when dengue gets worse, it takes a darker side, like it becomes dengue hemorrhagic fever. So, obviously, it can even lead to ARDS, pleural effusions, and DIC, obviously landing the patient from ward to the ICU, that is the intensive care unit, may contribute to hemorrhage. Adults rarely have classical dengue shock syndrome, but they may have a stormy and fatal course characterized by elevated liver enzyme, which I discussed earlier on, hemostatic abnormalities, and gastrointestinal bleeding. So, I guess the most important line, sorry, I'm saying line, the most important point in this dengue for a doctor to know is the pathogenesis of dengue. So it's so important that I think we should revise it in this very video. So, active or passive immunity to a dengue virus serotype different to one causing the current infection is a predisposing factor. This is the catch point. These heterotypic antibodies cause enhanced virus entry and replication in monocytes in vitro. Cytokine release is thought to be the cause of capillary leak, causing effusion, and DIC, which may contribute to hemorrhage. So, how will we diagnose it? As already we have discussed that leukopenia and thrombocytopenia is common. A diagnosis of dengue is easier in an endemic area when a patient has the characteristic signs and symptoms. Like we already discussed that anybody having malaise or headache and relative bradycardia and the particular rash, obviously in our setup, is most likely dengue. So it's quite easy to diagnose in Pakistan because the first suspicion in our country with such features, clinical features, goes with dengue. Mild cases may have a similar presentation to other viral infections, as obviously we have discussed it earlier. Now we have also discussed leukopenia and thrombocytopenia is common, and I already told you that diagnosis confirmed by either a fourfold rise in IgG antibody, Titer or isolation of dengue virus from blood or detection of dengue virus RNA by PCR. PCR might be expensive in certain hospitals. Obviously, we have to keep in mind all sort of patients. And if we are in private setup, it might be easy because the patients are affording. But PCR, obviously, we can go for PCR. But in our setup, I think that IgG is a more sensible approach. So, a patient having all these features and fourfold increase in IgG can be a really good catching point in diagnosis. Serological tests may detect cross reacting antibodies against flavivirus, including yellow fever vaccine. Now, management and prevention, we already know since our student lives that treatment is symptomatic, and obviously aspirin should be avoided due to its bleeding risk. Volume replacement and blood transfusion may be integrated in patient with shock. With intensive care support, mortality rates are 1% or less. Corticosteroids have shown of no help, no existing antivirals are effective, and the most important point is prevention. And how can we prevent it? Breeding places of Aedes mosquitoes should be abolished and adults destroyed by insecticides. And there is no licensed vaccine still available. So I guess though this was an introductory video regarding dengue, but even knowing the basics can be very helpful, and we shall inshallah continue in our next slides more regarding dengue. I shall read from certain other books like Oxford Handbook of Medicine, and inshallah we will discuss it, and we can even make MCQs regarding it, and we in some upcoming slides we shall also compare it with yellow fever.